EMS provider communication with the receiving facility is an important part of ensuring the proper and continuing care of patients. Whether the patient is being transported to a specific room in a routine transfer situation or is a critically ill patient heading to the cath lab or trauma bay, communicating the right information ensures that the care of the patient continues in an appropriate manner. In this video, we will explore modes of communication, types of communication that occur in the field, hear the receiving facility perspective of EMS communications, outline transmission scripts appropriate to different patient conditions, outline how to request orders from a physician, outline how to give face-to-face report once you've arrived at the receiving facility. Let's start by exploring the modes of communication. There are effectively two methods in use to contact receiving medical facilities: radio and telephone. Radio communications can be found in a variety of forms, including but not limited to VHF, UHF, 700 MHz, and 800 MHz. Regardless of the frequency range used, radio communications have some advantages and they also have some limitations. From an advantage standpoint, more than one provider can listen in on the radio transmission. This can be very helpful for receiving facilities. Providers can use portable or mobile-based radios, allowing the radio call to be made from the location most appropriate, in the house, at the scene, in the unit, etc. Providers do not need to keep emergency department or facility phone numbers handy. In disaster situations, you have less competition for frequency time, as the public is not sharing your frequencies. Now, there are some disadvantages of radio communication, and these include the range of transmission. Capability may not be adequate, particularly in non-repeated frequencies. The general public can more easily listen in to you through radio frequencies using scanners. Cellular phones have remade our world. Increasingly, cell phones are being used to communicate patient information to receiving facilities. Now, these have some advantages as well. It's a more secure communications link. It's harder to scan these frequencies. All receiving facilities have a phone. Not all have your particular radio frequency. And transmission of data can be done over cellular, for example, 12 lead. Now, cell phones have some disadvantages. You must have a list of specific facility phone numbers, and sometimes cell towers get busy, especially in disaster situations, which may prevent you from being able to call the facility. Additionally, only one person can monitor your patient information at the receiving facility in most cases. Types of communication include voice and data. Voice is readily apparent as one of the communication types used by EMS providers. This is how we inform the receiving facility of the patient demographics, diagnosis, relevant history and physical findings, treatment interventions, patient response, and our ETA. As we will discuss momentarily, the amount of voice information given is dependent upon the patient's condition, but a general rule of thumb is that providers should work from a basic script outline to keep communications concise, relevant, and as short as possible. Data communications is increasingly important in the care of patients. Some examples of data transmitted by providers to receiving facilities include 12-lead EKG rhythms, video, and pictures. Patients with cardiac-related concerns generally have a 12-lead ECG obtained by field providers. Some systems transmit that information to the receiving facility via radio or telephone wireless channels. Providers in some areas are using video to show the receiving facility patient assessment findings in advance of their arrival. As an example, one local service was using onboard wireless to communicate patient reports and exam findings to the emergency department via Apple FaceTime with the use of a simple iPad. Digital pictures speak volumes in some situations. Some trauma centers routinely receive pictures of the accident from EMS providers before the patient arrives, allowing surgeons to understand the kinematics of the trauma that they will be dealing with. Before we look at how we package our radio and phone reports to the receiving facility, let's take some time to hear from a local hospital facility. Kevin Wren, a dispatcher with Via Christi St. Francis in Wichita, has an extensive history in both pre-hospital care as well as hospital emergency communications. While Via Christi is just one of many facilities in our area, Kevin gives a nice overview of what the receiving facility needs from us as we communicate patient information. Let's listen as he gives us some hospital perspective.
Hello, my name is Kevin Wren, and I would like to welcome you to the emergency communications component of your medical training. To give you a brief background on my experience, my emergency career began in 1985. I've spent time as a firefighter EMT. I became a paramedic also. I've also spent time as a reserve police officer, and I've also served as a 911 dispatcher. What we want you to take away from this training is a very general understanding about how important it is to properly communicate, whether it's with the radio or whether it's through the telephone. Know or have a general idea about what you want to say. Don't shoot from the hip. You're dealing with a time element here. And the other thing that you need to understand is that you are part of one agency among multiple agencies. Here within our facility here at Via Christi, we maintain 3 different hospital channels. So while one of us might be talking with you on one channel, there might be another dispatcher talking on another one. Or there could be another agency waiting for their turn to speak to us on the same channel that you might be on. So, important things to keep in mind is having a general setup, a general idea in mind about what you want to say. Speak it very clearly, very precisely. Keep your flow very steady. Don't make it choppy and add a lot of adverse words like I, that kind of thing. The important component as far as emergency communications is just to get the message across, what you're dealing with, whether you're talking directly with 911 or you're talking with an individual like myself here at Via Christi Hospitals or any other healthcare facility. 4 key components to keep in mind. Number 1, you're giving a general sketch about what's going on with your patient. All the intricate details can be given once you actually get to the healthcare facility with your patient. We just need the general basic idea of the kind of patient that you have being brought to us. Have a general idea about what it is you want to say. Don't shoot from the hip. Rehearse it in your head. You're spending time with your patient, you know what you're dealing with. So rehearse it in your head before you pick up the microphone and talk to us. Also, keep your pace very steady and very smooth. Just go from one end to the other and keep it nice and flowing. Not too fast, not too slow. Many times as you're talking with healthcare facilities, such as Via Christi Hospital, St. Francis, you'll have patients that are going to need to receive some very specific definitive care, and there's going to be additional individuals that need notification. For example, if you're dealing with a STEMI alert patient, someone with significant chest pain, having a very intense cardiac event, there are notifications that need to be made on the receiving end. There are specialized physicians and nurses that need to be paged, blood bank individuals, a host of people that need to be notified. So make sure that when you're dealing with a case that's very specific, such as a STEMI alert, a trauma alert, a burn alert, give ample time to give proper notification to the people that need to be notified. Multiple pages will be sent to multiple people. So be sure to give at least bare minimum 15 minutes notification to the receiving facility so proper notifications can be made to have all the key elements in play for everyone to take place. I'd like to take this time to thank you for taking a part of this training. It's going to prove to be very beneficial to you as well as to the others that you're going to be serving. Ask plenty of questions, be very open-minded, and enjoy your healthcare professional experience. Thank you so much for your time.
Emergency departments can be busy places. Whether you're talking to an emergency department dispatcher, a nurse, or a physician, the provider should remember that they have a lot of things to do beyond listening to you talk. Your goal is to provide concise, accurate, relevant information in as timely a fashion as possible. To assure timely and accurate sharing of patient care information in verbal form, particularly for time-critical illness, scripts have been developed for providers to use, allowing for better transfer of information among providers and better teamwork between hospital providers and the hospital staff. The goal of a radio or verbal report is to provide essential information in an easily understandable and consistent format. To provide a clear, concise, and brief report to the facility, the provider must do some things before making the call. These include completing an appropriate history and physical assessment of the patient. If you don't have a clear understanding of the patient's condition, it will be hard to communicate effectively. Deciding on a specific course of treatment based on your assessment findings and diagnosis. Collecting your thoughts on what is pertinent and critical to communicate. And then communicate to the other healthcare team members the need-to-know components of your assessment and decision-making in a way that promotes continuity of patient care and appropriate responses to patient needs. To do this, different scripts have been developed based off of the condition and needs of the patient. It stands to reason that a non-emergent patient transmission can be much shorter and contain less information than the transmission for a patient with urgent or emergent medical issues. Critical patients may require an alert notification in advance of the patient information to allow the hospital to assemble a specific care team. Let's take a look at the different scripts. Patients who have time-critical illness or injury, for example stroke, STEMI, trauma patients, are best served by early notification of the receiving facility. This allows the facility to assemble a specific care team to meet the patient upon arrival. For this reason, as time-critical illness patient is identified, an alert is called to the receiving facility. These alerts, or pre-alerts if you will, should take no more than 15 to 20 seconds, and the format should follow this basic script. The patient's age and gender, your ETA, not in minutes but rather by clock time, Glasgow coma score if it's trauma, the triage level of the patient, the hospital destination, and the nature of the alert. If it's a trauma alert, specify the reason for the alert. So here are some examples. Medic 3 to dispatcher. Medic 3 advising a code red STEMI alert to St. Francis. 56-year-old female patient with ST elevation. ETA is 15-20 hours. As you'll notice in this example, what I've done is I've waited for the dispatcher to acknowledge. I've then advised my unit number, what I have, the triage, the age, gender of the patient, why the alert's being called, and my time of arrival in clock time. Another example. Dispatcher from Medic 33. Medic 33 advising a code red trauma alert to Wesley, 21-year-old male patient, gunshot wound to chest, GCS of 9. ETA is 23-30 hours. Again, in this situation, I've told the dispatcher my unit number, the triage, what's wrong with the patient, age, gender, why the alert's being called. I've added a GCS because it's a trauma situation, and the ETA in clock time. The alert is called to the hospital through the dispatcher. It is concise, with only enough information to give the hospital a basic idea of what is coming. The alert is called as soon as the need is recognized, and the dispatcher is the one who notifies the emergency department. ETAs are based again on clock time, not on number of minutes. Each report to a receiving facility should be accomplished in less than a minute and should begin with some basic information. All reports should include the following initial basic information: the medic unit number, the provider's certification and name, a triage level, patient's chief complaint, patient's age and gender. This basic information is followed by a script that is developed for different types of patients. For code greens, the script includes the initial basic information and really just two items. One, vital signs, only if they're abnormal, and two, whether the patient is okay for triage. For code yellow and red patients, the script is a bit more complex. However, the total time spent transmitting information should be kept to 1 minute or less. Here is the flow of the code yellow and red script beyond the initial basic information. First, request physician if needed for orders before you give the remainder of the report to avoid repeating information. Once you're transmitting information, initial vital signs and include oxygen saturation and end-tidal CO2 if applicable. Pertinent history, exam findings. What's the mechanism of injury for trauma or the nature of illness in a medical, and the patient's level of consciousness. A treatment summary including medications given and response to treatment. Any pertinent change in vital signs. The patient's initials, and if asked, the date of birth. Your ETA to the hospital. State the time of arrival again, not the minutes to arrival. For STEMI, include 12 lead findings, pain level, and change with treatment. State whether aspirin was given or not. For stroke, include the last time seen normal, a blood glucose, which new positive findings were found on the stroke scale. For trauma, include the GCS and the reason for a trauma alert if called. Code Blue patients require their own script, as the hospital will want to know some specifics to the resuscitation of this patient. This script includes the following items beyond the initial basic information. What is the pertinent history? When was the downtime? When were they last seen? Was it witnessed? Bystander CPR given? The number of shocks. Were they given by AED or manual shocks? Was shock advised initially on the AED? The initial and current EKG rhythm and any changes in the past 5 minutes. An end-tidal CO2 reading. Meds given, treatment summary and response, and the patient's initials, and if asked, the date of birth. While interfacility transfers may not be the most exciting calls you will run as a paramedic, they are a key part of the care of many of the patients that we encounter. Giving the right information to the receiving facility helps smooth the transfer process for the patient. In addition to the basic initial information, the following key points make up the script for inter-facility transfer patients. First, what's the reason for the transfer? Secondly, what unit is accepting the patient, if you know? The vital signs should be listed if they're abnormal. And again, the patient's initials, and if asked, the date of birth. By understanding the flow of these report scripts, you will become a better communicator for your patient and improve the transfer of care process. Paramedics and AEMTs often request specific medication orders from an emergency department physician or the online medical control physician. A key to getting your request for orders approved is to communicate clearly what you want and why it's important. The script for medication orders is given following the patient information, and it goes as follows. First, what medication are you wanting to give? Use the generic name, not the trade name. What is the dose of medication? What is the medication route you desire to use? And over what time will you administer it? Will it be fast push, slow push? And what's the indication for the medication? Here's an example. I'm requesting to give fentanyl 50 milligrams IV slow push for pain due to a suspected hip fracture. It's simple and it's concise. The physician knows exactly what I want to do and why and how. If approved, repeat the order back as given by the ordering physician to clarify your understanding. There are some things that providers should stop doing when talking to the receiving facility. Don't ask if the receiving facility or physician has any further questions or orders. If they do, they will ask. This is simply verbal graffiti that extends the time of the radio transmission. Providers should also stop giving medication lists and allergy lists unless immediately pertinent to the patient's acute complaint or requested orders. Whether you are a first responder giving patient information to a transporting agency or a transport provider handing the patient off to the receiving facility, it is important to give a clear, concise, and brief report. The script flows like this. your name and level of certification, the triage level for your patient, the patient's chief complaint, the patient's age and gender, pertinent history, for example, restrained driver of a high-speed rollover, ambulatory on scene, and pertinent exam findings, including information such as initial vital signs, mental status, cardiac rhythm, and including the number of shock, no shock for AED if applicable, any positive findings on your exam. Include the impression or diagnosis that you're treating. Include treatment provided and any change noted with treatment, including any medications administered and interventions performed. Sometimes you'll know the person you're giving a report to, and you will not need to give your name and certification level. Communicating with the receiving facility is essential to good patient care. With the information from your reading and the tools given to you in this video, you now have tools to begin practicing and refining your own ability to communicate effectively. Be safe and learn well.